know you are the father of flash therapy. Explain to me when this idea comes to you.
Everything started in Curie Institute.
Yes.
Where Vincent Favaudon, who was a scientist there, he was asked to irradiate mice for doing lung fibrosis, so for side effects. And he irradiated the mice with dose for fibrosis, but he irradiated one with flash. And a long time after, the veterinarian school called him and thanked him and said, well, thank you very much, you did a very good job for doing fibrosis in the lung, but you forgot to irradiate one batch of mice.
And you have irradiated this?
No, he was aware he had irradiated them with flash and there was no side effects. So he immediately realized that something was happening there, and he was starting working with us in Gustave Roussy Institute. And
this was when?
Well, it was 2009 or so.
Okay.
For maybe 2 years, he and our scientist, Marie-Catherine Vosnin, they came to me and said, well, we don't see side effects when we irradiate this way. And I told them, well, just check the dose, because your dose is not right. And after 2 years, they put a tumor in front of the beam, and the tumor disappeared. And from this moment, I really realized something was going on, because you have less side effects, the tumor disappears. So we move forward very fast from that point to where we are now.
Do you think that flash therapy will be the future in the field of radiation oncology?
Well, flash therapy is maybe an additional tool to try to increase the effect, the differential effect between tumors and normal tissues. It's certainly not the magic bullet. We will try to understand how we can have this on top of high conformity that we need for irradiating our patients, and on top of fractionation, if we can use that.
Then you think that flash will be something to be added to the normal treatments?
It has to be added, because it cannot replace what we are doing.
Drugs will be also complementary to the treatments that we are doing. Do you think drugs, the new drugs, the old drugs, cisplatinum, all the drugs that we are using now will be also the future, like a complementary treatment in radiation oncology?
Well, it's a difficult question. What we know is that when we combine the old drugs like cisplatin with radiotherapy, it's just better than radiotherapy alone, if we can do it.
Cervix in head and neck.
Yes, we have so many examples. Now we have so many drugs that are candidates maybe to improve what we do with radiation therapy. There are so many, I think it's overwhelming. But we need to test and see whether one of them will work. And it's not easy, because we have very, very few examples at the moment of new drugs, new molecular targeted agents or immunotherapy that is really working with radiotherapy. It's very little at the moment, but we should keep fighting on that.
We have a new technologies development nowadays in radiation oncology, and one of them is the adaptive radiotherapy. This is a type of treatment that is very time-consuming for physicians and for physicists. Do you think that adaptive radiotherapy will be also the future for us?
What happened in radiotherapy throughout the last decades is that we were more and more precise.
Yeah,
I mean, high precision was coming progressively with IMRT, with stereotactic radiotherapy. Even proton therapy is something really precise. So at some point, we are in a sort of plateau. We cannot be more precise than precise. And if we are more precise, at some point, we may miss the target. So we have to be careful to keep the margins, to keep everything safe. And from there, how are we going to improve things? I think it could improve still with molecular imaging, because we could be able, to pick some very small tumors somewhere. We know from the PSMA story that we can, when your PSA is raising, you can really identify a small node or small metastasis you can kill afterwards with radiation. So that's a way also to be more precise. Now adaptive radiotherapy is, it's not going to be a revolution in our field. It's a little bit of adjustment, of being a little more precise and then reduce perhaps a little bit, but very little, the margins.
But you know, I agree completely with you, because we have a precision in radiation oncology that diagnostic do not have. When you do a CT scan, when you do an MRI, when you do a PET CT scan, you have a precision that is not a completely true precision. You don't have 1 millimeter precision. You don't know exactly if this has 1 more millimeter or less millimeter.
Yeah, but they don't mind.
But the point is, if we are so precise in radiation oncology, we can skip out of the field a part of the tumor of the microscopic disease, and I agree completely with you. I think we have more to develop imaging to know exactly where the tumor is. What about artificial intelligence?
Well,
this is a thing that is everybody speaks about artificial intelligence.
yes.
What do you think about that?
Well, I'm really convinced it's going to improve our daily life because it's a tool again. I mean, it's not going to make a big revolution in the care of the patients, but our daily life for sure, because we have some tasks in radiation therapy which are really repetitive. When you want to do a contouring for breast cancer, for instance, my goodness, it's really...
this can be done by a machine.
Yeah,
and then
it's a lot of time. And same for dosimetry. For simple cases like this, if you have a auto dosimetry, which is automatic, then you spare a lot of time. So I really believe that it will be helpful, and it can be also bringing a lot of quality to what we are doing, because if you feed your model, your artificial intelligence model with good data you have checked, you have double checked, and you enter this in the system, then what you get back is quality. So I think we can gain on quality, maybe security of the treatment, and efficiency. So it's something that will develop anyway. It will be developed. I don't think we can stop this.
But what about hyperthermia? I don't know in France, but in Spain, hyperthermia is more and more important. What do you think about, for instance, hyperthermia?
Well, hyperthermia is a fantastic radiosensitizer and chemosensitizer. It's a pity it has not been used extensively. And it's hard to know and to understand why, but certainly we should try to keep developing this. I think new tools also are around, maybe more practical for use, and I think it's still a great opportunity for radiation therapy.
And hyperthermia can be like flash therapy.
Yeah.
A complementary tool
Absolutely.
To improve
Yeah.
the results that we obtain nowadays. What is the future for head and neck tumors? Locally advanced. I'm not speaking about the small tumors, the T1, the T2, that the majority are cured. I'm speaking about T4, T3 tumors.
Well, locally advanced cases, you know, what we have to do is try to avoid sort of mutilating surgery when we can preserve organ or functions. I mean, it's really important for the patient. But sometimes surgery is still better because it's more efficient in removing the tumor and curing the patients. And for those patients we don't operate, I think it's just amazing to see that we are still using cisplatin and radiotherapy as standard of care. It's 3 or 4 decades now since we've done it. And every time we try to challenge this by adding immunotherapy, adding whatsoever, never worked. So The only thing which was proved to work was EGFR targeting, but it's not working as good as chemotherapy. It's certainly not as efficient. So I think we have a really unmet clinical need for having more efficient and better tolerated treatment, because it's hard for the patients also, this radiotherapy plus chemo.
Yeah. But the question is, and the new treatments are so expensive with the new drugs added to the therapy. Do you think we can pay that? The public health can pay these prices of new drugs?
Well, I don't know. It's
immunotherapy, for instance.
It's
immunotherapy.
It's hard to say, but if you cure more patients and you cure without side effects, let's say, the cost effectiveness of this early treatment can be relatively favorable, because a head and neck cancer patient who does relapse, it's a lot of cost also, because he has to go to the hospital and a lot of complications and so on. So it could be very costly also not to cure the patients, in fact, especially for head and neck cancers, because it's quite devastating, what's happening there.
I have one last question to you. Between you and me, future of radiation oncology. What's the future of radiation oncology? In general, not particularly for one thing.
I think what is really important to see is that the whole oncology is moving forward quite fast in developing new drugs, more and more efficient. We saw that, for instance, the crizotinib targeting ALK. The initial one was working. Those they have now, crizotinib-like, they are better, more efficient, better tolerated. So this is not going to stop. We will see this movement for the next decades, and at some point it will be more efficient in curing patients safely. So what radiotherapy is going to do with this? I think one very important part of the development in radiotherapy is ablative stereotactic radiotherapy, because it's so complementary to all these new developments in oncology that we need really to make sure that we move.
Short treatments, very precise, can be combined with
You can repeat it, you can very, very little side effects, highly efficient. It's best, or the reference, I would say, ablative treatment that we have at the moment.
And protons has a place in that?
Well, protons is more complex, because proton, it's on the tumor itself is not going to make a difference. The proton are probably delivering less intermediate dose. Not the high dose. The high dose around the tumor will be around the same as what we do with conventional, but you have less intermediate dose. So it's hard to find a clinical benefit for that, but at least it's probably better to have less dose in a patient for the same result. So proton therapy is okay, but it's not maybe the revolution we expect. And it has been around for 40 years now.
And there is not so many clinical
the uptake is really slow. I mean, in Europe, I say we have probably 0.3 or maybe 0.4% of our radiotherapy patients treated with proton. So there is a long way. Even if we have 10%, it would be a very long way.
But the thing that I have today in the session that we have with the Cátedra Universidad de Barcelona Atrys, what I have said is that we have to work together. Radiation oncologists, medical oncologists, biologists, engineers. That is probably the future.
Radiologists.
And of course, I forget radiologists. And radiologists and nuclear specialists, nuclear medicine specialists.
Absolutely. Yeah.
Okay. My friend, thank you very much. That's always a pleasure to see you.